Hello, everybody. My name is Professor Nadya Pyatigorskaya. I'm a professor in Neurology in Pitié Salpêtrière Hospital in Paris, in France. So today we are going to talk about how to synchronize AI and the perfusion imaging in order to be able to improve the outcome of neuro-oncology patients that we will evaluate by the means of MRI. So why the subject is so interesting? Because we have a lot of difficulties in brain tumor imaging. It starts from the initial tumor management. So first of all, when we find a lesion, we need to know that it's actually a tumor or not an infection or something else. Then we need to go deeper and to characterize this tumor. Know supposedly what it is exactly as a tumor. We need to grade it, and then we need to suggest the management. Can be it resected directly, or should we do the biopsy? And if actually we're doing the biopsy, where should we do this biopsy? Then the tumor will be treated. If it's primarily brain tumor, usually we will have the surgery, then radiochemotherapy, and we will follow up the patient. And during this follow-up, frequently we will see some contrast enhancement that will appear. And when the contrast enhancement appear, we will actually need to know if it's radionecrosis or pseudoprogression, and then actually the tumor, there is no tumor recurrence, and then we can continue the same treatment because it's efficient, or if it's a progression, and then we should change the treatment. So the problem is that frequently we will do some mistakes. Sometimes we will see that there is a progression, we'll suppose it's progression, but on the end, on the follow-up, the tumor will increase. So we were right. Or we will see that there is no progression actually, and it will continue this way. And we also were right considering that it was a tumor response. But we can sometimes see the increase of the tumor, and we will supposedly think it's progression, but finally, on the follow-up, it will decrease, and it was pseudoprogression or radionecrosis. And then we were wrong, and maybe we changed the treatment, and we were not supposed to do it. Or the same, we will supposedly think that the tumor is regressing, and actually it will increase because it was a pseudo-response. So the idea is to try to go deeper into imaging in order not to make these mistakes. The follow-up of glial tumor is usually quite close, every 1 to 3 months after the surgery and radiotherapy, but there is no gold standard. And usually we try to do multimodal MRI, so use multiple sequences in order to see the tumor infiltration flare, the tumor cellularity with the diffusion to see if there is any restriction. And particularly, we want to see if there is any neoangiogenesis in the tumor using the perfusion. So how would we use the perfusion? So there is the classical sequence of perfusion. It's DC perfusion, where we are going to measure the cerebral blood volume. And then we will compare between the cerebral blood volume in the tumor and in the healthy zone. And we will see if there is an increase of cerebral blood volume, and we can also calculate the cerebral blood flow. So it's published in quite a lot of reviews, and meta-analysis show that performances are not that bad. When it's increased, it's probably a progression, and when there is no increase, it's probably a response. However, the performance is not perfect, and particularly the problem is that the threshold is extremely variable between the studies. So sometimes we have really hard time only based on the cerebral blood volume to conclude on individual cases. So there are also another problems. As we were saying, we can have a pseudo response where we think when the patient is particularly treated by Avastin, we will think that actually there is an improvement and decrease of cerebral blood volume, but finally the lesion is still progressive. We can have also difficulties, especially close to cortical regions where there are a lot of vessels and where there are a lot of post-treatment changes. We can have difficulties to know if there is increase of cerebral volume in this lesion. We don't know if it's progressing or not. And another problem is that, like here, we have a tumor. There is an increase of cerebral blood volume. So, okay, we suppose there is neoangiogenesis. But do we know what is actually the prognosis value? Can we say, okay, because there is neoangiogenesis, the patient will progress or not? Remains still a question. So there was also another technique of perfusion that was proposed, that is arterial spin labeling. The idea of this technique is that we will mark the spin before they arrive to the brain, and we will do the images with and without this tag, and we will deduce the cerebral blood flow. The problem is that actually we will have the only marker of cerebral blood flow. We will not have other markers. So here we see that there is an increase of cerebral blood flow. So supposedly there is a progressive lesion. And here also, when we go to our lesion that we had hard time to see before, if there was any hyperperfusion on ISL, we have less artifacts. So we can see that there is hyperperfusion. However, the diagnostic performance remains quite variable. And also, we still don't have the answer to this prognosis question. So, in context of these difficulties, there were also PET markers that were proposed. So, the most used PET marker is FDG. FDG is highly available, but the problem is that there is strong brain physiological burden. And also the glucose metabolism is variable, and there are a lot of reasons why this metabolism can increase. It can increase in case of infection, inflammation, systematic disease, and finally the sensibility and specificity for glial tumor diagnosis is quite low. We can have no abundance in some oligodendroglioma. It can be variable in metastasis. Usually it's quite high in lymphomas. So other markers were also proposed that are amino acid markers such as DOPA and FET. The idea is that using visual analysis, will compare the lesion to striatum. We can also do the measurements. And then if the lesion burden is higher than the one of striatum, we will conclude that it's probably a progression. The problem is that, of course, the lesions that are close to striatum, but also overall the sensibility and specificity remain still imperfect, and these markers are quite expensive and the availability is limited. Moreover, we have analyzed the difference between the segments that have high PET burden and high perfusion. And actually, they don't always coincide. Supposedly, that there are different informations that will be brought by perfusion and by PET. So PET cannot replace the perfusion. So that's why we need really to go deeper in the perfusion analysis and to get some new markers that can help us to respond to these multiple questions that we still have. In this context, we really need to have some new perfusion markers. And Circar Medical propose us some new biomarkers. These biomarkers are based on specific vascular analysis model that have also less noise and less artifacts that are really problematic in perfusion, as we have seen. And it allows us, helpful to AI, to get some advanced map that will model the perfusion heterogeneity data. And in this context, we will have the CTH, that is very interesting, that's capillary transit time heterogeneity, and it will show us the changes in capillary morphology that will be hypoxia-induced and will correspond to this heterogeneity angiogenesis. We have also the oxygen extraction fraction, that is the maximum possible oxygen extraction on given voxel. And we have the CMRO2, that is the cerebral metabolic rate of the oxygen. And this would correspond to particular aggressive portions of the tumor. So let's see how we can actually analyze these markers and how they can be helpful to us. This first example is an oligodendroglioma, but actually it was first assessment, so we didn't know yet that it was oligodendroglioma. But we see that it's aggressive, large tumor, and we cannot resect it directly. So we will, of course, first go to the biopsy. So the question is, what should we biopsy? So here we have all this large infiltration, almost no contrast enhancement, and there is this large portion that is hyperperfused. Some of it corresponds to high CMRO2, that is aggressive, but only one portion corresponds to high CTH. So we will suppose that we should go to this portion because we have most biomarkers that are suspicious in this portion that is probably the most aggressive. Another example is this grade 3 astrocytoma. It was EDH positive. It was treated first by subtotal surgery and radiotherapy and PCV. And here we see some new contrast enhancement. The RCBV map is quite difficult to read. We don't quite well see any hyperperfusion. There are some bleeding, some post-surgery changes. We don't know. The PET was intermediate, but actually when we look on CTH and in OF, we see that there is this really suspicious zone where there is an increase of both of the markers, and actually it corresponded indeed to a progression. More interestingly, there was a second lesion. This lesion was quite liquid, and so we suppose that actually it was radionecrosis. But when we look in our markers, we don't see much increase on RCBV. The PET is intermediate, but we see exactly the same profile with CTH and OF. And actually, this was also the second tumor lesion and not radionecrosis. Another example, this is this glioblastoma. So this is the first assessment of the tumor that we see here. The tumor is quite aggressive, but well limited, and it could be treated by the surgery. Of course, after the surgery, the patient was treated by radiotherapy and chemotherapy. And here we see the follow-up. So on this follow-up, we have some new contrast enhancement that appeared. On FLAIR, it's heterogeneous, and we don't know actually what it is. On an RCBV, we cannot really conclude because there might be some hyperperfusion, but actually it's very close to the cortex and it's not different from other cortical regions. But when we look on CMRO2, we see that there is a real increase in CMRO2. So we can suppose that this part of the lesion is a tumor recurrence. And we follow up this patient, and actually the contrast enhancement didn't change much, but there was a double bundle that appeared and OF increase, and actually indeed this CMRO2 increase was really predictive of the tumor progression. Another case. Here we have temporal glioblastoma, so it was treated by radiochemotherapy, and then the chemotherapy was changed to Ciceniu and Avastin, and here we have follow-up on the Avastin. So we see this contrast enhancement. Actually, when we see the contrast enhancement, of course, each time I have to look onto one without contrast, and here we see that part of it is just bleeding, but not all. There is still some contrast enhancement. So what does this contrast enhancement mean? We will look on the RCBV map. On RCBV map, we see some hyperperfusion corresponding exactly to this contrast enhancement. So we'll think, okay, it might be a progression. But when we look at the RCBV map, we should also think that some of this hyperperfusion might be not hyperperfusion, but just the leakage. And we always, in these cases, should look at RCBV that is leakage corrected. And actually, when we look at leakage correction, there is no any hyperperfusion left. So then we follow up this case, and there was no increase on in contrast enhancement, and CMRO2 was negative curve also, and finally this case was only the radionecrosis, and it was also confirmed by PET when we see that there is no increase on dopamine. So this is the case that I was talking to you about in the beginning. So here we have this lesion. That is, the patient has a grade 3 astrocytoma, ADH negative. He was treated by surgery and radiochemotherapy, and we have this lesion recurrence. And actually, there is hyperperfusion in this lesion. But when we look on CTH map and on OF map, both of them are negative. So what does it mean? We don't know, but we continue to follow up this patient without treatment changes. And actually, 2 years later, there was no progression at all. The lesion was partly regressive. There was little less hyperperfusion, and all the markers were still advanced markers. They were all still negative. And when we look on Doppler, we can see that there is a PET double bond decrease during 2 years. So finally, the negative values of CTH and OF was very strong in order to tell us, well, there is this hyperperfusion. Okay, but finally, the lesion is not progressing. Another case is also this lesion that we can see here. So it's quite difficult because there are a lot of vessels. So it's difficult to interpret if there is any hyperperfusion or not. We feel like there is not. But actually, we can see that there is this portion with CTH increase. And the patient was followed up, and sometimes later, it was oligodendroglioma. It was not evaluated very fast, but 3 years later, we see that there is this portion that appeared that corresponded to the region where we have the CTH increase. And actually, it was the tumor recurrence. Now we can see that there is an increase on RCBV and also in oxygen extraction fraction. So everything concords, and this CTH increase was predictive of the future progression. In this other case, this is the first tumor imaging. So this is man, 72 years old, and we suppose that it's glioblastoma. But actually, when we see well and we look on these images, all the markers are increased, but there is no real heterogeneity of this marker increase as we usually see in glioblastoma. Everything concords perfectly. And finally, it was not glioblastoma, it was lung cancer metastasis. Because everything was concordant, there was no heterogeneity, there were no markers outside the contrast enhancement, and finally the lesion could be resected. Sometimes the perfusion can be difficult in the tumor that secondary tumors. So more markers we have, more we are sure in ourselves, like in this lesion. So here it's the metastasis that was treated by gamma knife, and we have this residual contrast enhancement. And when we look on all the maps, they are all negative. And so because they are all negative, we can be more sure in ourselves to say, okay, this contrast enhancement, it is just radionecrosis and there is no residual. Finally, the last example is this lesion that you can see here. So this is primary tumor assessment. We can see the strong contrast enhancement with some mass effect, increase diffusion signal. And of course, we will do the perfusion imaging. So if we will look on the RCBV values without any leakage correction, we will see that there is some hyperperfusion. But actually, if we look at the leakage correction, then there is no increase of RCBV. And in this lesion, with strong contrast enhancement, with no increase on RCBV, we can do the correct diagnosis that was, of course, lymphoma. So to conclude, there are a lot of diagnostic difficulties, both for primary tumor assessment and for follow-up in brain tumors. So we really need some new markers to improve the tumor management. And in this context, there are new care medical markers to consider, such as CTH, OAF, and oxygen extraction fraction, and others. So all these markers, they will bring us new information and will have a real added value to standard markers and to PET. So in perspective, what we want to have is the more precise diagnosis, but also to be able to give a prognosis on the tumor evolution in order to adapt the treatment to make it earlier and more appropriate and to arrive to a real personalized medicine for each patient. Thank you very much for your attention.